Hello and welcome to today's webinar on common mistakes with the skilled nursing facility patient-driven payment model, or PDPM. My name is Mary Sue Gardner and I'm going to be your presenter for today's webinar. And I'm joined today by other members of Provider Outreach and Education, as well as Medical Review, who are going to be helping with questions and answers. My objective for today's webinar is to provide participants with the essential information and some reminders to improve your understanding and implementation of the patient-driven payment model, or PDPM, in the context of skilled nursing facility services. And I hope to accomplish this by reviewing an introduction of PDPM and the importance of accurately capturing information that's really essential for reimbursement and quality of care. We will also highlight some key documentation requirements for various components of PDPM, such as MDS assessments and the ICD-10. And we will identify some common pitfalls or mistakes in capturing that can negatively impact PDPM outcomes. And if time allows, we'll answer any questions to address your specific concerns and queries. This is our disclaimer slide. And the disclaimer slide is to inform you that this webinar was developed. When it was developed, it was done using the current Medicare laws, rules, and regulations. But as we all know, those laws, rules, and regulations can often change. If they change tomorrow, it's your responsibility as a provider to make sure you're following the laws, rules, and regulations that are in effect tomorrow. So we're going to answer questions based off the information and the facts given, specifically using those laws, rules, and regulations. Remember, Medicare's rules, regulations, laws are the final determination in coverage. Finally, CMS prohibits you as a provider from recording this presentation for profit-making purposes. Since we don't know what you would potentially do, we ask that if you are recording it, that you please stop now. We are actually recording this for you, and pending the outcome of the recording, it will be available on our YouTube page as an encore of this event. So this slide is acronyms. When it comes to skilled nursing facility, and especially PDPM, there are tons of acronyms, as you can see. So this slide includes some of the acronyms that I am probably going to use during the course of this presentation. So if I happen to use something that you don't know what that means, please refer back to this slide. I'll make every effort to try to say it in long version first, but sometimes I get ahead of myself and I don't always do that. So a little bit of computer issues going on here. All right. So what is PDPM? How is it that it came into effect, and why did it start? All right. The patient-driven payment model, or PDPM, is a case mix classification system for classifying our SNF patients into Medicare Part A covered stay and classify them into a payment group under the SNF's prospective payment system. It actually became effective October 1st, 2019. And PDPM replaced the old RUG utilization group, or resource utilization group, which was the RUG 4. Under RUG 4, most patients were actually classified into a therapy payment group. which use primarily the volume of therapy services provided to the patient as a basis for the payment classification. This created incentives for SNF providers to furnish therapy, and furnish therapy that often wasn't even necessary to their skilled nursing facility patients. And it was done regardless of that patient's unique characteristics or goals or needs. So PDPM actually eliminated this incentive and improved the overall accuracy and appropriateness of SNF payments by classifying patients into payment groups that are based on specific data-driven patient characteristics. All this while simultaneously reducing the administrative burden for SNF providers. So PDPM classification system is structured to include beneficiary interviews and input into the data submitted to the MDS. So how are these rates calculated? So under PDPM, each patient is classified into a group of each of 5 case mix adjusted components. And those components include PT, OT, speech language pathology, nursing, and the NTA group, which is the non-therapy ancillary. There is also an additional non-case mix adjusted component to address the utilization of SNF resources that do not vary by patient. So different patient characteristics are used to determine a patient's classification into a case mix group within each of the case mix adjusted payment components. So these patient classification components are then used for payment grouping. The PDPM classification methodology utilizes a combination of 6 payment components to derive payment. 5 of the components are case mix adjusted to cover utilization of SNF resources that really vary according to patient characteristics. Again, these patient characteristics include like PT, OT, SLP, nursing, and non-therapy ancillary needs. There's also additional non-case mix adjusted components to address utilization of SNF resources that do not vary by patient. So different patient characteristics are used to determine a patient's classification into a case mix group within each of the case mix adjusted payment components. PDPM also includes a variable per diem adjustment that adjusts the per diem rate over the course of their stay. So the payment for each component is calculated by multiplying that case mix index, or CMI, that corresponds to the patient's case mix group, or CMG, by the wage adjusted component based on payment rate, then by the specific day in the variable per diem adjustment schedule when applicable. These payments for each component are then added together along with non-case mix component payment rates to create a patient's total SNF PPS per diem rate under PDPM. So I know that's a handful, but it will all make sense in a little bit. So this is different from RUG 4 because under RUG 4, payment was derived from a combination of 2 case mix adjusted payment components and 2 non-case mix adjusted components. The RUG 4 payment methodology assigned patients into payment classification groups called RUGs. Within the payment components, based on various patient characteristics and the type of intensity of therapy services provided to that patient. So under PDPM, 6 payment components are utilized to derive payment. The PDPM uses clinically relevant factors rather than volume-based services to determine Medicare payment. Under the PDPM patient characteristics, those are used to assign patients into CMGs or case mix groups across the patient component, and that's what derives your payment. Additionally, the PDPM adjusts the per diem payment to reflect varying costs throughout the day. And again, I know this is a lot of payment classification information, although we're not focusing on the billing and payment information today. I really thought and feel that it's important for you to have some background of how this all came about and how this plays in, because it's going to help you with some of those common errors that we see if you have a better understanding of what goes into it. So as we move on your slide that's shown, we're going to talk about these clinical categories. These clinical categories are used as the primary PDPM diagnoses, giving weight to the calculations of PDPM rates for PT, OT, SLP, and nursing components. Now, other diagnoses will affect the non-therapy ancillary component as well. A mapping of the ICD-10 diagnoses and or surgical category used to classify a SNF resident into each of the 10 clinical categories is available on the SNF section of CMS's website. Neither Jennifer or Rachel is going to put a link to that in the chat for you. So given similar costs among certain clinical categories as they relate to PT and OT costs, CMS collapsed certain clinical categories together under the PT and OT components. So for instance, major joint replacement by itself is actually collapsed into PT and OT category as major joint replacement or spinal surgery. But other non-orthopedic surgery, acute neurologic are then further collapsed together. While under medical management, like acute infection, cancer, pulmonary and cardiovascular and coag, those are all collapsed then into medical management. So I'm not going to review everything that's on the screen for you today. You have that in your handout as well. So again, in addition to those patient clinical categories, the patient is also classified into a PT and OT component group using the patient's functional score. So the patient's functional score, which really is coded out of section GG of the MDS form, is derived by assessing the patient's usual self-performance in the ADL task during the first 3 days of the facility stay. The functional score is based on the resident's performance in eating, oral hygiene, toileting hygiene. It includes the sit to lying, lying to sitting on the bed, sit to stand, chair or bed to chair transfer, and toileting or toilet transfer assessed, and those are all assessed in the first 3 days of admission to the facility, with the admission day counting as day 1. And functional scoring is one of the factors used to calculate the PDPM rate, especially for PT, OT, and nursing components. Again, if you want more information on the details of the functional score, you can use that last link that Rachel provided in our chat, and it'll take you to the PDPM overview on the cms.gov page. So what are the PDPM components? All right, as you can see that on this slide, each component utilizes different criteria as a basis for patient classification. This change really made the focus unique to the needs of the patient and the payment specific to the needs and the care of the patient. So as you can see, for PT and OT, it's clinical category and functional scores. For SLP, the presence of acute neurologic conditions, speech language pathology related comorbidity or cognitive impairment, mechanically altered diet, and swallowing disorders. Nursing, same characteristics as were used under the RUG 4, and for the non-therapy ancillary, really with focus with the comorbidity scores. So by addressing each of the patient's unique needs independently, PDPM really improved patient accuracy and payment accuracy. Under PDPM, all SNF patients are classified by their components of care, and it highlights the importance and complexity and unique qualities of the SNF care and the SNF patient. PDPM focuses on the uniqueness of the individual's needs and the characteristics and goals that you have for each of these patients. And this is really all done by addressing each individual patient's unique needs independently. So PDPM really improved patient care accuracy, payment accuracy, and really encourages a more patient-driven care model for our beneficiaries. So how is PDPM, how are the categories established? Well, the minimum data set. The MDS is the clinical assessment tool that encompasses the physical and cognitive status, active diagnoses, nutritional status, behavioral status, emotional, special treatments, etc., as well as your therapy services. It represents the patient's clinical status based on the assessment reference date, or ARD, and the established look-back period for the covered days associated with the MDS. ARD is the date the MDS is completed. So it is required to be performed once during the first 8 days of the patient's SNF stay, which is the 5-day PPS assessment. Completing the MDS then establishes a PDPM category for your Medicare Part A payment. It must be completed and locked into a state repository. We, as your review entity, we then use that MDS that's submitted and locked into the repository to complete our medical review of the claims and make sure that everything that, you know, the billing category that you got matches your documentation and everything is appropriately captured. Here is where I have to stress that a good MDS coordinator that's trained in all aspects of SNF care and knows how to complete the MDS is invaluable to your skilled nursing facility. A good MDS coordinator is going to know what to look for, what information to look for, especially in the look-back period, what diagnoses need to be captured, what assessment reference date should be used in order to maximize the amount of reimbursement for your facility. So if you have a good MDS coordinator, keep them, pay them well, they deserve it. Okay, again, there are 3 SNF PPS assessments under PDPM. As we said, the 5-day assessment, There is also an interim payment assessment and a discharge assessment. The 5-day and the PPS discharge assessment are required assessments. The IPA or interim payment assessment is optional and will be completed when the provider determines that the patient has undergone a clinical change that would require a new PPS assessment. Again, if you have a good MDS coordinator, they will know when this is necessary to really maximize reimbursement and accuracy of reporting. Let's briefly discuss some of the determinants of payment on the MDS assessment and how those play into payment. So for PT and OT, some of the determinants of payment, the primary reason for SNF care or PDPM diagnoses, which is coded in section I00200B. Of the MDS assessment. It also includes functional status, which is also coded in section GG of the MDS assessment, as well as a variable per diem rate. Under speech language, the determinants, there's a little bit more here, and they include, again, the primary reason for SNF care, or PDPM diagnoses, again, captured in that same section of the MDS, and the cognitive status. So the BIM score, which should be coded in section G of the MDS assessment, and the presence of a swallowing disorder or mechanically altered diet, coded in section K of the MDS assessment, as well as other speech language pathology-related comorbidities that are coded in section I of the MDS assessment. So as we continue on this next slide, under nursing, the determinants of payment include clinical information from the skilled nursing facility stay, functional status that's coded in section GG of the MDS assessment, extensive services received, which is coded in section O of the MDS assessment, such as tracheostomies, ventilators, isolation, the presence of depression coded in section D, which includes your PHQ-9 on your MDS assessment, as well as any restorative nursing services that are coded in section O of the MDS assessment. And finally, under the non-therapy ancillary determinants of payment, you have comorbidities that are present that are coded in section I, extensive services received coded in section O, again, such as tracheostomy, ventilators, isolation, and as well as any variable per diem adjustment rates. Again, I know this all seems a little heavy on background and what goes into PDPM classifications and calculations, but I assure you this is all for a reason. And the reason is to understand how not gathering all this information, reporting it accurately, completing your assessments at the right time can affect your overall classification and reimbursement for your care. So we're going to continue with this just for a little bit and talk about some calculations and a little bit about reporting before we dive into how this affects your documentation and overall payment. The choice of PDPM diagnoses has really become rocket science for an MDS nurse, as it gives more weight in the calculation of the PDPM rate for the facility. So each patient has different reimbursement rates as compared to RUG 4 PPS rates of the past. It is highly recommended for the MDS nurse to make calculations which can determine the highest acceptable reimbursement rate for your facility. The MDS software programs automatically calculate PDPM rates once the MDS assessment is completed. And there's various ones out there like Point Click Care, Matrix, Net Solutions. Those are just a few that I know that are out there right offhand. It's highly advisable for the MDS nurses to review each assessment to ensure that all skilled services are captured during the assessment period to really maximize that reimbursement rate for the facility based on that patient's diagnoses and acuity. For the non-therapy ancillary component, each diagnosis has a corresponding score which is multiplied to the federal NTA case mix index. What that means is the higher the score, the higher the NTA rate. All PDPM components are assigned an appropriate score to multiply to the federally assigned case mix index group. After the PDPM rate for each component is determined, the sum of the PDPM component rate is added to the fixed non-case mix rate, which will be the final reimbursement rate for the patient for the entire skilled nursing facility stay. Again, unless there is an interim assessment that needs to be done. This can be revised if there's changes in a patient's condition. So, which makes additional skilled nursing facility services, like say a patient has to have IV medications that were not initially administered, it makes them available to capture as, or to capture in your MDS assessment. For situations like this, the MDS nurse will choose to complete, again, that interim payment assessment or the IPA to make sure they capture these changes and eventually increase the daily reimbursement rate. The MDS nurse should be alert to these changes to ensure timely completion of the MDS assessment. So PDPM considerations for your MDS nurses. In ensuring that you capture all diagnoses and pertinent information and to maximize facility reimbursement, I suggest doing some of the following, which most of you as MDS nurses, I'm sure, are already doing. So inquiries before admission to gather information about your patient before they even come to you. Request from the hospital for history and physical, progress notes, consults, etc. Request for labs and imaging studies and surgical reports, or both, whichever is applicable. Upon admission, formulate a PDPM group to review the chart and come up with the resident's primary or principal diagnoses and do the ICD-10 clinical category mapping. Medical records departments should already code and map for a clinical category to be able to determine the principal diagnoses code and to calculate expected daily rate for the facility using either the manual PDPM worksheet or software-generated calculations. Section GG, the Rehab and Nursing Functional Scores, should be completed on the MDS form for indicated ADL tasks on days 1 to 3 of admission, with the admission date being day 1. Recalculate expected daily rates based on completed rehab and nursing functional scores and review those principal diagnoses. Ensure that you are capturing everything prior to completion of the 5-day MDS. And that's why I say it's important for you to have an interdisciplinary team and to get that accurate information from your interdisciplinary team and to know if there is information or things that happened in the look-back period back into the hospital look-back period that could maximize your reimbursement. So your interdisciplinary team, your nursing, social services, dietary, activity staff, all disciplines should complete all their assessments on time to capture all skilled services and to help you accurately calculate the resident's daily rate prior to the completion of the transmission of the MDS 5-day assessment. So for nursing, daily Medicare charting should focus on all possible nursing clinical categories, special care situations, special care high, special care low, clinically complex, behavioral symptoms, et cetera. Those are all things that go into your categories. Under social services, make sure you're conducting interview assessments for the BIMS or the brief interview for mental status and mood on the assessment reference date or a day prior to the ARD. So on or a day prior to. Dietary, complete section K on your ARD on or a day prior to, indicating if the resident has a swallow disorder, especially if they're on a mechanically altered diet, like pureed or mechanical soft diet. Coding of these areas will affect the speech case mix group as well. So that was a lot of information. Remember, your 5-day MDS assessment basically sets the tone for your entire stay. So let's talk about some of the common issues and findings and some of the common mistakes that we know are happening that affect your reimbursement. We know SNF patients have many complex needs and may suffer from a number of different conditions, but a diagnosis coded in section I0020B should represent the primary or main reason that that person is being admitted. The primary SNF diagnoses may or may not be the same that the patient was admitted to the qualifying hospital stay for. So in other words, there's no necessary reason that the primary SNF diagnoses have to match the primary hospital diagnoses from the 3-day qualifying stay. So what you should be gathering is what is the #1 main reason they have to come to the SNF versus going home or going to a different place of service. The software you use will use the code to place the patient into a category for payment. And make sure you're using the most specific diagnoses, coded out to the most specificity that you can. J100, there is a surgical piece to the diagnosis. So did the resident have a major surgical procedure in the last 30 days? So make sure you're paying attention to that as well if you have a surgical patient. Failure to obtain a complete diagnosis is one of the most common mistakes that the MDS nurses do. They fail to get that complete diagnosis for the NTA qualifiers. This means that the resident's medical records in the care plan software lack the supporting documentation to back up those MDS items. Of course, all coding and diagnosis information is available in the RAI User's Manual. So MDS nurses can simply refer to the manual if they need further guidance on that. To provide a complete diagnosis, the nurse must ensure the code and the documentation accurately reflect each other. And that you are working with your physicians and that you make sure that your physicians are reporting the diagnoses of why the patient is being admitted to the skilled nursing facility. So that's one thing, you know, you really want to work with when you're gathering all that information prior to admission, making sure you're looking at all of those diagnoses and that you're coming up with and your physician is diagnosing the need for the patient coming to the skilled nursing facility in that information when they come in. Okay. The place you have the most control as a SNF is making sure whatever software you're using, again, whether that's point of care or care tracker, you want to make sure you have good documentation submission. Be sure that you are monitoring in real time. Every system has some way of showing charting omissions. If nothing has been charted regarding ADLs for all 3 shifts, you are not going to capture a good ADL score. It's imperative to get the picture of the patient around the clock, not just during the day when they're the most awake or having the most pain meds administered, etc. Daytimes, they may be more independent, whereas evenings, they may be more tired or more worn out from therapy, and you're going to see more dependencies. If you have weak charting going on at night, you are definitely going to miss out, and really you're leaving money on the table. So failure to collect relevant data from all 3 shifts before coding the ADL scores could really affect your reimbursement and payment rate. Coding, again, for activities of daily living can be a bit overwhelming because several caregivers contribute towards the resident's medical documentation. And accurate ADL coding directly impacts the quality measures, consequently affecting how much reimbursement the facility is going to receive. Therefore, if the ADL coding has been underscored, this can really be a costly error for the facility. The relevant ADL data is collected on multiple occasions and from multiple different team members to determine the ADL scores. Thus, it's not a process that is single member, complete. So facilities must ensure their ADL charting is accurately documented in their care planning software so that each team member can monitor for compliance and accuracy. And remember, try to avoid gaps in your charting where nothing has been charted for an entire shift. All right, not understanding the non-therapy ancillary or NTA. We need to dive deep into hospital records to be sure if there are diagnoses that got dropped in the hospital and didn't come over in the transfer, that you are accurately identifying these things, because maybe they were not in the hospital for fibromyalgia, but they have it and are being treated for it. You should include that in your list of diagnoses so so it can be accurately captured for your NTA points. Don't fail on querying your physician for diagnosis clarifications. Selecting the correct ICD-10 code for a specific NTA component can be challenging, especially if a nurse is busy. In such cases, it's common for an MDS nurse to use a simple or an unspecified ICD-10 diagnosis code that's written by the physician. Further complicating matters in the fact that the resident may have multiple comorbidities going on. In such cases, MDS nurses must ask the physician to establish and confirm the diagnosis. So again, failure to do so is going to result in incomplete HIPS codes and inaccurate PDPM reimbursement. Unspecified codes are a significant problem because they do not accurately represent a resident's diagnosis. Therefore, it's up to the MDS nurse to check and collaborate and communicate effectively with the physician to confirm those specific diagnoses. All right. Since the diagnosis coded on the 5-day MDS, which you do again in section I0020B, is the primary reason for the skilled stay, it largely determines that reimbursement for the entire Medicare stay, unless again an IPA is performed. It is important to ensure that that diagnosis provided by the physician is the actual primary diagnosis. So again, remember the beneficiary must require skilled care for a condition that was treated during the qualifying hospital stay or for a condition that arose while in the SNF for treatment of a condition which the beneficiary was previously hospitalized for. The applicable hospital condition need not have been the primary diagnosis that precipitated the beneficiary's admission to the hospital, but could be any one of the conditions present during the qualifying hospital stay. So again, for example, the purpose for the admission encounter is rehabilitation. Sequence first the code for the condition for which this service is being performed. So for example, if an admission or encounter for rehabilitation is for right-sided dominant hemiplegia following a CBA or stroke, make sure you report the code. In this case, it would be I69.351, which is hemiplegia and hemiparesis following a cerebral infarction affecting the right dominant side as the primary diagnosis. It may not always be an aftercare code like once we originally did, and that was that Z47.1. Remember, the active diagnosis is defined or as defined by the physician, has to be documented, and it has to be a documented diagnosis of the last 60 days, and it has to have direct relationship to the resident's current functional status, their cognitive status, their mood or behavior, the medical treatments they're receiving, nursing, monitoring needs, or risk of death within the last 7-day look-back period. As we move on, insufficient charting. MDS nurses will perform an initial chart review or should perform an initial chart review when assessing new admissions into the skilled nursing facility. This allows them to become familiar with those new residents all while alerting them to any NTA comorbidities. So reviewing a resident's admission chart, preferably on day one, is essential. Hence, the MDS nurses know upfront which NTA comorbidities a resident will have, which consequently allows them to create a better care plan. So failure to gain such information can impact the resident's care because caregivers are less aware of the problems due to inaccurate nursing documentation. Additionally, accurate reimbursement can only result from precise documentation of all NTA comorbidities. The reality is, the quicker that the nurse identifies the resident's needs and their strengths and weaknesses in the nursing home software, the faster the facility can process the reimbursement and receive payment. All right. So as we move on, the next issue is, hang on, not reviewing documentation. Sorry, my computer is not acting very friendly. So I have to have deliberate pauses because sometimes it just clicks through several slides on me. All right, so not reviewing documentation. Failure to review documentation thoroughly will negatively impact your PDPM reimbursements, as missing documentation will not accurately reflect the services provided. So therefore, the MDS nurse must ensure that all clinical documentation is accurate, that it's up to date in the facility's long-term care EHR. Additionally, facilities can provide PDPM training courses for their nurses to ensure their staff are up to date on all the latest PDPM regulations and also knowing your facility's expectations. And finally, not accurately scoring the NTA components. So the NTA components use a weighted comorbidity score. So for example, high cost conditions or extensive services count for more points, which you then use to assign the SNF resident into an NTA case mix group. So a resident's NTA score is the sum of the points associated with each comorbidity that they have. For example, a resident with IV medications, that will be 5 points, and it will be coded in the MDS in section O. Diabetes mellitus, so that's 2 points, and that's coded in section I. Isolation, which is 1 point, which is also coded in section O, and a wound infection, 2 points, which is coded again in section I. This patient would have a total NTA comorbidity score of 10. So the NTA case mix groups are based on NTA score ranges. So the ranges are listed here on your screen and the grouping that they go into. And you can actually find this in the RAI manual as well. The bottom line is that accurate payment in the NTA component depends on coding each and every NTA comorbidity that the resident qualifies for according to coding instructions in the RAI manual. There are 50 conditions and extensive services that can contribute points to the resident's case mix group calculations in the NTA component. So it's important to make sure they are coded correctly and captured in your documentation. If we can't see it in your documentation, we have to remove it for consideration off of what you coded. Do not use whatever simple term or unspecified ICD-10 diagnosis the physician writes down. Don't use the thought process, if the physician didn't specify, I shouldn't specify either, because unspecified codes may not represent an accurate diagnosis that is accurate and complete for your resident. You should identify any opportunities to collaborate with the physicians, confirm more specific diagnoses, and use the mapping tools that are on CMS's website. So it was a lot of information. We provided you with essential information and reminders to improve your understanding of PDPM. And we did this today by reviewing an introduction to PDPM. We highlighted those important areas of accurate documentation, and we talked about those pitfalls and mistakes that we commonly see providers making that really are going to negatively affect your overall reimbursement of your patient. So at this time, I'm going to ask my nurses if there are any questions in the queue that have come about. If you have a question, go ahead and place that in the chat and send it to all panelists. So Rachel or Jennifer, do we have any questions that have come in?
I don't see any questions right now in the queue, in the chat.
All right, perfect. Well, I want to thank you for taking time to join us for the Skilled Nursing Facility event. Since there is an ongoing 5-claim sample skilled nursing facility review happening for all of our skilled nursing facilities, we really encourage you to watch our live events page for more SNF education. Also, remember in our survey, you can tell us what other SNF education you would like for us to consider doing in the future. On behalf of myself and all of provider outreach and education, as well as medical review staff, I want to thank you for your participation in today's event. We look forward to your survey comments and hope you will join us for future events. And you may now disconnect.